Welcome back. We're here again today with Dr. Alexander. Our last video, we talked about jowls, nasolabial folds, marionette lines, surgery. And today we're going to talk about everything eyes. Droopy eyes, saggy eyelids, hollowness, discoloration. Dr. Alexander, welcome back to part two. Part two is very dear to me.
Okay.
I have a lot of clients, including myself, that are concerned about our sagging eyelids and our brows. You know, we keep doing neuromodulators, Botox, Xeomin, Dysport, the list goes on, and they still have that sagging brow, or they've got excess skin on their eyelids. Let's talk about it.
Well, I mean, is like as you see as well in your practice, it is a very common thing that we see in ours, that people come in requesting some sort of treatment, and they're not always exactly sure what, but to address the periorbital area, you know.
Shall I put my glasses on so you can talk? Here, I'll give you even the pointing pencil.
All right, I'll be careful not to pull.
Don't poke me eye.
Yeah. So people come in saying, you know, I've got too much upper lid skin excess, it's heavy, it's hooded, I can't put on eyeshadow, or they'll say my brows just feel heavy. I hear that a lot. It's just, you know, they look fine in the mirror, they just feel heavy. Also, people complain about the lower lids, you know, the look of tiredness because they've got hollowing, fat, pseudo herniation, all that sort of stuff. So we spend a lot of time kind of looking at the anatomy globally and saying, okay, so you've got some upper lid skin excess. Is that the only issue? For many people, I would say, you know, again, if you had to draw a line in the sand, probably at about age 40 or above, is, you know, the brows are really starting to contribute to that. And so if the brows here, if I show in
yeah, absolutely.
So, you know, if the brows are sitting low, then it makes that upper lid skin excess. If we look here, it makes that look exaggerated, it looks too much.
Don't make me look
Please. But if we lift it, not that we would ever lift it this much, but, you know, lifting that brow kind of shows how that upper lid excess gets better. And so for, you know, anybody who comes in complaining about upper lid skin excess, we say, okay, well, we got to look at your brows and see if that needs to be addressed as well. There's a little bit of a, you know, you think, okay, well, I got a little bit of skin there, so I got to remove that. And, you know, I think there's been a paradigm shift even between when I was in training, you know, 15 years or so ago, and now where we are less reductive. You know, we know that a youthful eyelid brow complex is one that's volumized. So it's not a scenario where we want to remove every little bit of excess skin, fat, and muscle. We want to keep some good volume there. And so I would say I'm a lot more conservative now than maybe I was at the beginning of my practice. And then with the brows, you know, again, everything's moving towards a kind of a more minimal access approach. So, you know, when we do a minimal access endoscopic brow lift, it's literally just 4 small incisions, 2 1 centimeter incisions here, 2 1.5 centimeter incisions in the hairline that are totally imperceptible when it's all healed up. And through that, we can elevate the brows and put them back in their natural position.
When you're elevating and doing those incision points, are you elevating at the muscle layer?
Yeah, deeper than that. So, I mean, depends exactly where you are, but in the forehead, you know, as we get to the top of the brow here, we're literally on the bone, kind of lifting the ligaments off of the bony attachments there so that we can truly release them. Okay. And then, you know, through this temple incision, so on the side here, we're on top of the fascia of the muscle, so the deep temporal fascia, and we're again going right down to the rim of the orbit and releasing all of those ligaments and soft tissue attachments to the bone so that it's truly mobile and we can lift that freely. And so we know, you know, when you're doing brow lifting, it's really the release that's the most important part, not the suspension.
Okay. Because years ago, you know, 10, 15 years ago, it was just so common for people to have the excess skin removed, right? Just that upper lid bleph. I know when I'm assessing clients around their eyes, I look at, you know, how much lift can we get with a neuromodulator? Yeah. I look at volume loss. Dermal fillers are kind of my last resort. I'm using a natural gel now, which is your own, you know, autologous PRP, but even then I'm so cautioned, right? So when someone comes in for an assessment or a consultation on an upper lid, are you looking at, you know, 50% of the time, including a brow lift at the same time? Or is it, again, just really depending on their anatomy?
It's probably more than 50% actually, because by the time you get to that point where you're bothered by the upper lid skin excess, you're probably at that age 40 or above cutoff, where, not cutoff, but kind of lined in the sand, where usually above that, there's some component of brows. So yeah, I don't know exactly what the number is, but probably more than half of the time we're doing a brow along with the upper bleph.
What about the skin tissue? Like, obviously, you know, a lot of women, you know, I do a lot of energy-based devices. I do fractional CO2, I do all therapy, RF. I mean, different lasers. Are you combining your upper lid blephs with any kind of devices as well, or peels, or?
Yeah, so often when we're doing, you're doing the whole kind of eye complex, you end up doing upper lids, brow, and lower lids. And the lower lids is kind of a different animal. There's a lot more different components to it. And for the skin there, like almost every single time we're treating it with a laser afterwards to get some tightening of the skin. And then oftentimes if we're doing the lower lids, we're doing the whole face, because again, you're already there and most people need improvement of the overall skin quality.
Right.
So yeah, it is definitely a multimodality approach. And it's not just, with surgery, it's not just removing the skin, suspending the brows like we talked about. Often we're doing fat grafting as well. So if there's volume deficiency in the upper lid area, in the temples, in the teardrops, in the cheeks, we're adding fat, autologous fat. So we're taking fat from the belly, the thighs, the flanks, and then we're injecting that small volumes very judiciously into the areas that support the periorbital area so that you kind of get the best rejuvenated look possible.
And we did a video on fat. We were discussing different options for eye areas, and fat transfers were one of them.
Yeah.
People have been asking me online, why can't a med spa do fat transfers?
Well, I guess anybody could do anything, but I mean, it would be something you'd ideally want to do under general anesthesia. It's not comfortable doing that. You could certainly harvest the fat under local, but injecting it would be difficult to do if you weren't under general anesthesia. It is a very delicate procedure. It takes a certain amount of experience, takes like a soft touch.
Yeah.
It's not hard to get a complication or untoward results. So I would certainly caution anyone from, getting that kind of treatment at a random med spa.
Yeah. Now, what about downtime? If you were going to do a blepharoplasty with a brow lift, what kind of downtime are people looking at?
For most stuff in the face, it's kind of in that like 2 to 3 week window. So stitches come out at 1 week. By 2 weeks, most bruising is gone. You could probably cover it with makeup. And by the 3rd week, basically all bruising is gone. So again, going out for dinner, visiting a friend somewhere, it'd be about.
Or if you're like me, I don't care. I just like.
Or you just get big glass.
It's a conversation piece.
That's right.
It's good marketing for you.
Yeah, that's true.
One of the questions that I get a lot is treating dark circles under the eye.
Yeah.
Whether you're a light-skinned individual or someone of your skin tone, right?
Yeah.
And this is common. And sometimes I am challenged. I do have a lot of options in my practice, but can we talk a little bit about that and how you strategize treating them?
I feel like it is a very challenging area to treat. And I think the farther I've got in my practice, the more conservative I've become. I'm like much less likely to do filler in the teardrops than I used to be, I would say. I find it to kind of be the most challenging area to treat non-surgically. And so, especially lately, I find that I'm more often steering people towards surgery, I guess being a surgeon, but also just knowing that there is a limit to what the filler can achieve in that area. And now I don't do PRF like you do, so, you would have a different experience for that. But, I think if for kind of mild tear troughs, I think filler can help. I think when you're setting expectations and saying, look, we can make it 70 to 80% better, but not much better than that, then I think, filler can be a good option. But eventually you get to a point where the tear troughs are so deep or there's other anatomy at play. The skin is really crepey and loose. I find those patients really don't do well with filler. Or if there's a lot of fat that's protruding out, that fat pseudoherniation, the filler just can't kind of catch up to make it look smooth.
We call it the jelly roll.
Yeah, I mean, jelly roll I like to treat with a little bit of Botox into the muscle there, but when the fat is protruding out, really surgery is your best bet. And the nice thing about surgery is that you can address each of the kind of issues individually. So for the fat that's protruding, you can make an invisible incision inside the eyelid and reduce or remove some of that excess fat. For the volume deficiency as a hollow, if that hollow is causing that dark shadowing, then in that case, I typically go to fat grafting. So again, I take fat from the belly, flanks, thighs, and then inject that best, really nice quality fat.
I'm making my list of everything I want to get done.
You will add it to the list for sure. So we just inject a little bit of that into the tear trough area. And, the quality of that fat, I think also helps the skin quality in general. There's some amount of stem cells or something in there that seems to like just bring some brightness to the skin. And then usually we're doing like a laser as well to resurface that crepey skin to get a little bit tighter. So, to me, it's like more and more, the farther I get in my practice, the more I think surgery is your best option for the lower lids as opposed to non-surgical stuff.
Even the discoloring.
The discoloring, so again, if it's pigment within the skin, then surgery is not necessarily going to help with that. And a lot of times, if it's not a lightening type cream, then it's just makeup is your best option, particularly for people of South Asian background where they get that pigment in the skin. But for a lot of people, it's not, there's a few things at play. So it's a bit of the hollow, It's a bit of the, light just not kind of fitting the skin nicely. Yeah, exactly. And it's a bit of the pigment. And so you can at least address 2 of those 3 things by revolumizing with your own fat.
Thank you for watching. If you have any questions or comments or questions for Dr. Alexander or myself, please put them in the comments section below. Make sure you subscribe and give us a thumbs up. Dr. Alexander, I want to thank you so much for being a part of our first part and our second part video.
Thank you for having me.
And I learned so much today, and we'll definitely have you back.
Sounds good.